Welcome, everyone. My name is Evan de Zambuja, a medical oncologist from the Jules Bordet Institute in Brussels, Belgium, and it's my pleasure to be here in this edition of ESMO On Air to discuss metastatic breast cancer and the ESMO guidelines real-world cases. Today with me in the panel, we have Dr. Metastasico, who is going to present a case, then Professor Seoka Im, who is going to put in perspective the ESMO clinical practice guideline, and then I have the pleasure to have a faculty to discuss the case as well, to discuss the guidelines, Professor Nadia Harbeck and Professor Giuseppe Corigliano. So what do you want to achieve with this webinar today? We want to promote the evidence-based quality cancer care by disseminating our ESMO clinical practice guideline in the oncology community. In this case, we're going to select a case to discuss, and then you can discuss how the guidelines apply to it. So we're going to present a critically review the ESMO clinical practice guideline for this particular case. And we want also to discuss how the ESMO clinical practice guideline and recommendations, what is the impact on cancer care? How can you implement this in daily practice? And how can you distribute this to the entire oncology community? At the end of this webinar, there will be an online questionnaire to check whether this was fulfilled. Just to set the stage, the magnitude of problem with metastatic breast cancer. So on the left-hand side, you can see the proportion of patients with de novo metastatic breast cancer around the world. So you can see there is a quite incidence. If you look at data from the global breast cancer case in 2022, we had 2.3 million of new cases of breast cancer, and this is going to increase by 38% by 2050. You also had almost 700,000 deaths globally because of breast cancer, and this is expected to increase by 68% by 2050. If you look particularly at the data for the metastatic breast cancer in the United States in 2025, approximately 52 new cases have been diagnosed, and we have today in 2025, approximately 170,000 patients living with metastatic breast cancer in the US. But it was interesting to see the work of our French colleagues showing the overall survival improvements that we have been facing for these patients. Here you can see the median overall survival for the 3 breast cancer subtypes. The green line represents the HER2 positive with approximately 56 months. The red line represents hormone receptor positive HER2 negative, about 43 months. And the triple negative is the blue line with less than 16 months. But also, this group showed in a cohort, particularly in this cohort with hormone receptor positive HER2 negative, that is the case we are going to discuss today, with over 21,000 patients between 2008 to 2022, there is a constant improvement in the median overall survival. 2008 to 2010 was about 41 months, 2017 to 2019, 47 months, and 2020 to 2022, not reached yet. So this is for the first time you see, for the last 17 years, you see an improvement in median overall survival for patients with metastatic breast cancer, and this is across all 3 subtypes, even if the triple negative has still the worst overall survival. And this data comes from the Advanced Breast Cancer Global Decade Report, and if you focus on the right-hand side, you can see the 5 years overall survival using the SEER database. We see that between 1992 to 2021, there is an improvement in the 5 years overall survival. It was 23%, and now we have 33%. So there is an improvement in the median 5 years overall survival for those patients. And I just want to highlight that the new ESMO clinical practice guideline for patients with metastatic breast cancer is going to be published very soon. And without any further ado, I would like to invite Metastasico to present her case for patients with hormone receptor positive, HER2 negative metastatic breast cancer. Thank you.
So hello, good afternoon. My name is Metastasico. I'm a medical oncologist working with breast cancer in the University Hospital for Tumors in Zagreb, Croatia. It is my great pleasure to take part in today's ESMO Guidelines webinar series focused on metastatic breast cancer. Here are my declarations of interest. I will now present a case of a premenopausal patient with a recurrent metastatic hormone receptor positive, HER2 negative breast cancer as a platform to open the discussion on ESMO metastatic breast cancer guidelines. Here I introduce Mila, who is a 43-year-old premenopausal, otherwise healthy woman, mother of two, working as a real estate agent and running a very active life with a lot of amateur sport hobbies such as mountaineering. In October 2022, she self-palpated a lump in her left breast and a further diagnostic procedure was undertaken. The imaging revealed a tumor mass extending from upper to lower outer quadrant of left breast with a suspicious lymph node in the ipsilateral axilla. Core needle biopsy was done, and the pathology report confirmed a ductal invasive breast carcinoma of no special type, hormone receptor positive HER2 negative, so a luminal B-like HER2 negative cancer. And at that time, we only had cytology confirmation of the axillary lymph node involvement. Both tumors in the breast as well as the axillary lymph node were marked with a tissue marker. So it was a multiple tumor with 3 tumor masses, clinically, radiologically T2N1 disease, and the CT scan of thorax, abdomen, and pelvis as a screening for distant metastatic disease was negative. Patient was discussed on our multidisciplinary team, and it was decided to start the treatment with neoadjuvant approach. So the patient received chemotherapy consisting of anthracycline and taxane treatment, as well as GnRH and analog for ovarian function suppression. The treatment overall went well, with some expected toxicity of chemotherapy, and the checkups such as ultrasound in the middle of the treatment, as well as preoperative MRI, showed tumor regression dynamics. The patient underwent surgery. It was a radical surgery of the breast, so skin nipple sparing mastectomy with reconstruction and axillary dissection. Final pathology report confirmed luminal B-like HER2 negative disease, but somewhat extensive residual disease, with cancer cells still present in all 3 tumor masses in the breast, as well as 2 out of 5 harvested lymph nodes were positive. So the pathology report corresponds to RCB class 2. So it was a YPT2N1 residual disease after neoadjuvant chemotherapy. The patient started with adjuvant letrozole, as well as continuing GnRH analog. She was offered adjuvant zoledronic acid as bisphosphonate, which she decided not to go for, and she was scheduled for regional nodal irradiation. Since it was May 2023 and we just got the drug reimbursed, we also started with this patient abemaciclib treatment. Overall, she experienced severe diarrhea due to abemaciclib, despite dose reduction, and at some point, the patient informed us of her decision of discontinuing abemaciclib. Afterwards, after the diarrhea ceased, patient felt much better and had a satisfying quality of life and everyday functioning. She continued with letrozole and ovarian function suppression, and we scheduled her for regular checkups. A year later, in August 2025, patient presented with symptoms, which were predominantly worsening of the fatigue as well as back pain. So she underwent further diagnostic procedure, and the lab tests revealed anemia, an increase in alkaline phosphatase levels, as well as increase in tumor markers. And the CT scan showed multiple liver lesions, as well as some osteolytic bone lesions in lumbar spine. The liver lesion biopsy was done and confirmed metastatic breast cancer, ductal invasive breast carcinoma of luminal B, like HER2 negative biology, and the patient also had PIK3CA mutation. At that time, following the results of INAVO 120 trial, we had the opportunity to treat our patients through a patient name program, which required also in the beginning to test our patients with comprehensive genomic profiling of the tumor. So we did the NGS, and here is the report. So the report confirmed presence of PIK3CA mutation, as well as BRCA2 mutation and the ESR1 mutation. Although this patient was a candidate for genetic counseling and testing in the very beginning and moment when she got her first diagnosis of breast cancer, we only had this result now, and the germline testing of BRCA mutation was negative. So the patient was scheduled for palliative irradiation of painful bone metastasis. After the dentist checkup, the bisphosphonate was reintroduced, so she started receiving zoledronic acid, and she underwent bilateral annexectomy as a mean of permanent ovarian suppression. As oncology treatment, she now started with fulvestrant, palbociclib, and inavolisib, according to INAVO 120 regimen and per schedule. Patient spent in total 5 months on this treatment with somewhat good tolerance to treatment and some expected toxicity due to palbociclib, as well as acceptable and satisfying glycemia control. At the second regular checkup in February this year, CT scans revealed new metastatic lesions in the lungs, and the biopsy confirmed it was still a luminal B-like HER2 negative disease. The patient was somewhat symptomatic. Now she kind of lost motivation and was prone to continue only with oral treatment. Therefore, taking into account patient's preferences as well as biology and the dynamics of the disease, we decided to start with capecitabine in reduced dosage with plan of escalating in case of good tolerance, and the patient tolerated the treatment pretty well. Unfortunately, at the first regular checkup in the beginning of May this year, the CT scans showed lung and liver progression, and due to repeated headache, the patient was checked by neurologist, and the brain MRI also showed 3 new brain metastatic lesions. So the question is now how to proceed with this patient and what to offer to our patient in the sense of further possible diagnostics and treatment approach. Following that, I would open a couple of points for discussion for our panel today, for touching diagnostic and treatment considerations. First of all, the question of testing timing, not only for germline BRCA testing, but also for molecular profiling. So the optimal timing and also the type of testing, tissue, and liquid biopsy. Further, we can see that this patient progressed during her adjuvant endocrine treatment. and it was only 1 year after discontinuation of abemaciclib. So whether this is an optimal patient to consider the INAVO 120 protocol, and should we maybe consider whether there is also a CDKI resistance in this patient. Also, in case we decide for that approach, what would other options for this patient in first line be? Following that, how to proceed as a second line option in the situation where we possibly have all options available, but also in the real clinical scenario where some of the new treatment options are still unavailable in a real clinical everyday practice. Also, following that, question about third line options in this kind of scenario, especially due to CNS progression and the brain metastasis. And in the end, I would like to tackle also the topic of oligometastatic disease and how to approach these patients and whether, when, and how to incorporate the local ablative treatment into oncological treatment approach. With this, I thank you very much, and I open the floor for further discussion. Thank you.
Hello, everyone. I'm Seoka Im from Seoul National University Hospital, Seoul, Korea. It is my great pleasure to participate in ESMO Guideline webinar series on metastatic breast cancer. First of all, I would like to express sincere thanks to Dr. Anna Tececi-Buger for submitting this interesting case. I will provide critical analysis of the case focusing on key decision points and the supporting evidence from current ESMO guideline. These are my disclosures. This slide summarizes the full treatment trajectory of our patient Mila, a 43-year-old premenopausal woman without family history of breast cancer. She was diagnosed as clinical stage 2B, luminal B, HER2-low disease, October 2022. She received dose-dense AC followed by weekly paclitaxel with GnRH analog as neoadjuvant therapy, achieving stable disease with 21% reduction. After skin sparing mastectomy and axillary lymph node dissection, pathology confirmed YPT2N1 RCB2. She received adjuvant letrozole with ovarian function suppression and abemaciclib for 15 months, discontinued by patient choice due to diarrhea. She experienced relapse 12 months after stopping the abemaciclib while still on letrozole with ovarian function suppression with bone and liver metastasis. Liver biopsy showed that PIK3CA mutant ER-positive disease with ESR1Y537S mutation and a BRCA2 frameshift mutation on tumor NGS were high variant allele frequency of 41%, suggesting the possibility of germline variant. However, germline BRCA testing by OncoPanel was negative. This case represents clinically relevant and challenging scenario of a young premenopausal patient with early relapse hormone receptor positive HER2-low metastatic breast cancer after intensive adjuvant therapy, including CDK4/6 inhibition. Several important discussion points arise when critically reviewing the management according to the ESMO guideline. I will organize my discussion around 7 key points. Systemic treatment for early breast cancer. When should we test the germline BRCA mutation, and does the result change our management? Indication for olaparib, adjuvant or metastatic. How do we interpret early disease progression after adjuvant CDK4/6 inhibitor therapy? Was the first-line choice of INAVO 120 appropriate? What was the second-line option, and was there any missed opportunity with PARP inhibition? What is the optimal approach in the third-line setting given CNS involvement with visceral prognosis? And if I have a time, I will briefly touch about the local overlap treatment indication. This slide addresses the adjuvant treatment decision. Mila's CPS EG score is calculated as 3. Scoring 1 for clinical stage 2B, 1 for pathologic stage 2B, and 0 for the hormone receptor positivity, and 1 for grade 3 histology. This meets the threshold for the Olympia eligibility, which requires CPS EG score of 3 or higher in hormone receptor positive non-PCR patients. However, olaparib was not offered in the adjuvant setting. The reason is straightforward. Germline BRCA mutation testing has not been performed at the time of adjuvant treatment planning. This highlights the first discussion point, which I will address shortly. BRCA testing should ideally occur before or at the time of initial diagnosis, not defer to relapse. Our indication for the abemaciclib was clear on the MONARCH E 1, 2, 3 node positive disease with grade 3 histology and Ki-67 of 35%. We received 15 months of a planned 24 months before discontinuation due to diarrhea, a clinically relevant decision that we will revisit when discussing CDK4/6 inhibitor resistance. This is the summary of recommendation regarding germline BRCA mutation. Patients with HER2-negative metastatic breast cancer and germline pathologic or likely pathologic variant in BRCA1 or 2 should be offered treatment with PARP inhibitor, olaparib, or talazoparib, independent of hormone receptor status, as an alternative to chemotherapy. Prior treatment with anthracycline taxane should not be required before offering patients with metastatic breast cancer and germline BRCA mutation treatment with the PARP inhibitor. Nor should hormone receptor positive patients be required to demonstrate complete endocrine resistance. This slide summarizes the international criteria for germline BRCA testing. ASCO and SSO guideline recommended testing for all breast cancer patients aged 65 or younger. And NCCN 2026 version 3 sets a threshold of age 50 years based on clinical criteria alone, which is even more inclusive. At 43 years old, Mila meets this testing criteria. The key message here is that testing should have been initiated at the time of initial early breast cancer diagnosis in 2022, not deferred until metastatic relapse. Timing to discussion point 2 is when should germline BRCA testing be performed? And one of the important discussion points in this case is delaying identification of the BRCA2 pathogenic mutation. According to the ESMO Living Guideline, all patients with HER2-negative metastatic breast cancer should undergo germline BRCA1 testing regardless of age, family history, or subtype because PARP inhibitor represents a standard treatment option with level 1 evidence. This patient was 40-year-old at diagnosis with biologically aggressive luminal B disease with high Ki-67 residual disease after neoadjuvant chemotherapy and early recurrence despite adjuvant endocrine therapy plus abemaciclib. In respect, germline BRCA testing should probably have been performed already in the early breast cancer setting. In Mila's case, germline BRCA testing was negative by the oncopanel assay at the time of metastatic diagnosis. However, the somatic NGS report from the Foundation Medicine identified the BRCA2 frameshift mutation and serine 1982 frameshift mutation with variant allele frequency of 41%. A VAF of 41% is suspicious for germline origin, as somatic-only mutation is a diploid tumor would typically show lower allele frequency. Importantly, earlier identification of germline BRCA2 mutation could potentially have changed the therapeutic strategy substantially. The patient might have been eligible for adjuvant olaparib after completion of local treatment and chemotherapy based on Olympia criteria, and the PARP inhibitor therapy could have been incorporated before the development of metastatic disease. The oncopanel germline test was negative. However, in case like Mila's, when the VAF appears a suspicious high for the purely somatic heterogeneous event and HRD phenotype, further supports possibility biallelic BRCA2 inactivation. Additional germline BRCA testing may be cautiously considered to cross-validate whether the BRCA2 alternation is truly somatic in origin. If germline BRCA mutation is confirmed, olaparib or talazoparib are the standard of care option as demonstrated in Olympiad and EMBRCA respectively. Even if the alteration proven to be true somatic in origin, the ESMO Living Guideline 1.2 states that PARP inhibitor monotherapy may be considered in patients with tumor harboring somatic pathologic or likely pathologic BRCA1/2 mutation. Therefore, PARP inhibition would remain a biologically and clinically relevant therapeutic option in this setting. This slide references a practical framework for the germline BRCA counseling in the clinical practice. Let's move to the ESMO living guideline framework for the diagnosis and staging in metastatic breast cancer. I want to draw particular attention to the biopsy recommendation. At first diagnosis of metastatic breast cancer, a biopsy should be performed, confirm the histology, and reassess tumor biology. Specifically, ER, PR, HER2, and relevant biomarker including germline BRCA and PIK3CA ESR1 HER2 low or ultra low status. Milla's liver biopsy in August 2025 to fulfill this requirement and provide the critical PIK3CA mutation ESR1 mutation status that guide for first-line therapy. In Milla's case, the liver biopsy was also performed in August 2025, and the repeat biopsy at lung progression in February 2026 revealed an important change in HER2 expression had evolved from 1 positive to positive. This reclassified HER2 low status in theoretical significance. It makes Milla's eligible for the transplant of deruxtecan in later line, as I will discuss later. For context, this slide shows the ESMO first-line recommendation for the patients who are endocrine sensitive, that is, those with de novo metastatic disease or relapse more than 12 months after completion of the adjuvant endocrine therapy. In this patient, an aromatase inhibitor combined with CDK4/6 inhibitor remains the standard of care. However, Milla does not fall into this category. She relapsed during adjuvant letrozole 12 months after stopping abemaciclib. Discussion point 3. What does CDK4/6 inhibitor resistance mean in Milla's case, and how should it influence our treatment decision? Let me begin with the endocrine resistance definition. Secondary endocrine resistance is defined as relapse during adjuvant endocrine treatment or within 12 months of completion of it. Milla relapsed 12 months after stopping the abemaciclib while still on letrozole and GnRH analog. She is therefore classified as secondary endocrine resistant. Now, an important nuance: Milla discontinued abemaciclib at 15 out of 24 months due to diarrhea by patient choice, not due to disease progression. This is an incomplete course. Whether this continued true CDK4/6 resistance is debatable. The molecular finding, ESR1 mutation and cyclin D1 amplification and TP53 mutation represent acquired resistance to endocrine therapy and likely reflect the selective pressure from the aromatase inhibitor and ovarian function suppression rather than the exclusively from abemaciclib. Importantly, the ESMO guidelines support re-challenging with CDK4/6 inhibition in the metastatic first-line setting even after adjuvant CDK4/6 exposure, provide relapse occur at least 6 months after discontinuation. This patient relapsed while still receiving adjuvant endocrine therapy, and the selected first-line treatment, if she has a PIK3 mutation, is fulvestrant plus palbociclib, inavolisib, or fulvestrant with CDK4/6 inhibitor, maybe palbociclib or ribociclib. This slide shows the ESMO treatment algorithm for the endocrine-resistant hormone receptor-positive, HER2-negative metastatic breast cancer, and the pathway that are applied to Milla for patients with relapsed or within 12 months of adjuvant endocrine therapy. The guideline recommends fulvestrant combination with its CDK4/6 inhibitor, or if PIK3CA mutant, fulvestrant plus palbociclib plus inavolisib. Milla underwent bilateral salpingo-oophorectomy to achieve permanent ovarian function suppression before starting systemic therapy, which satisfies the guideline requirement for the ovarian function suppression in premenopausal or perimenopausal patients. This table summarizes the first-line therapy for hormone receptor-positive, HER2-negative metastatic breast cancer. As shown here, if you have a PIK3CA mutation, it is better to adopt the INAVO120 regimen, consists of fulvestrant plus palbociclib with inavolisib for the PIK3CA mutation status, because you have a randomized clinical data. So INAVO120 is a randomized phase 3 double-blind placebo-controlled study that assessed inavolisib or placebo with palbociclib and fulvestrant in patients with PIK3CA mutant hormone receptor positive, HER2 negative metastatic breast cancer. And this met its primary endpoint with a statistically significant and clinically meaningful improvement in the PFS, prolonged from 7.3 months to 17.2 months with addition of inavolisib, and median overall survival was significantly longer with inavolisib consistent across all pre-specified subgroups. Subgroup analysis from INAVO 120 using baseline ctDNA confirmed that the benefit of inavolisib was maintained across diverse genomic background, including patients with ESR1 mutation like Mila and PTEN loss and p53 mutation like Mila. This slide summarized the ESMO recommended targeted therapy option based on genomic alteration. I want to emphasize that hierarchy for the PIK3CA mutant disease relapse or within 12 months of adjuvant endocrine therapy, Mila's exact situation. And the option on this slide, capivasertib, alpelisib, elastrant, and PARP inhibitors apply primarily to second line or beyond. Critically, Mila have multiple action of alteration, PIK3CA mutation, ESR1 mutation, and BRCA2 frame shift. This polyclonal emphasized landscape means sequential decisions are complex and should be governed by the highest tested evidence at each line of treatment. This slide presents real-world data from our institution. If the patient has germline BRCA1-2 mutation, has shorter PFS compared with germline wild type, or the patient who are not tested by the germline BRCA inclusion criteria, and patients with germline BRCA mutation or TP15 mutation or co-mutation showed shorter PFS after first-line endocrine treatment with palbociclib. Let me move to discussion point 5. What were the second-line options after INAVO 120 failure, and were there any optimal chosen? After 5 months on INAVO 120, Mila developed 5 new pulmonary lesions with other sites remain stable. The lung biopsy revealed HER2 expression upgrading 1 positive, 2 positive, each negative, which classify her as HER2 low. This is the most therapeutic significant finding in this time point. It opens the door for the trastuzumab for Destiny Breast 04 when TDXD demonstrated median PFS 10.1 months and median OS 23.9 months in the hormone receptor positive HER2-low cohort. The choice of capecitabine was reasonable for her, and she had received anthracycline and taxane in the neoadjuvant setting, and single-agent oral chemotherapy is a guideline-supported option. However, the optimal second-line choice in the respect should have been either a PARP inhibitor or TDX, given her this somatic BRCA2 mutation. These represent potentially more effective option with higher response rate and more durable benefit compared with capecitabine. There is also a clinical system point here. If germline confirmation of BRCA2 had prioritized after FMR report, olaparib or could have been prescribed as second line before capecitabine, which would have been the guideline preferred sequence anthracycline and taxane. This comprehensive landscape diagnosing treatment option across line of therapy. For the field is rapidly evolving, and the blue represent current approval or guideline-supported therapy, red represent recently approved agent, and pink represent investigator option in the late phase development. For Mila's trajectory, I want to highlight the sequential opportunity in INAVO 120 first line, then the TDX given HER2 low status, and PARP inhibitor if germline or somatic BRCA mutation is confirmed, and the guideline participated repeated biopsy progression to assess the receptor status and genomic alteration, exactly what was done in Mila's case, revealing the HER2 upgrading and ESR1 persistence. These slides from ESMO Living Guideline present the second-line and beyond treatment algorithm, stratify whether the patient remains a candidate for the endocrine therapy or not. For Mila, a second-line progression, given that she had already received fulvestrant with INAVO 120 and had ESR1 mutation, endocrine rechallenge options are limited. the not candidate for the endocrine treatment pathway leads toward ADC. Please remember Capetlo 291 evaluated capivasertib, an oral AKT inhibitor combined with fulvestrant versus fulvestrant alone, who had progressed after aromatase inhibitor therapy. The trial included a significant proportion of patients with prior CDK4/6 exposure, and results show the median PFS improved of 7.2 versus 3.6 months overall, with greater benefit in PIK3CA AKT PTEN altered subgroup. In Mila's case, capivasertib could theoretically be considered, although she already received the inavolisib. To complete the second-line discussion, the discovery of HER2-low status and lung progression creates a strong rationale for T-DXd as second-line or beyond. DESTINY-Breast04 demonstrated T-DXd significantly improved both PFS and OS compared with chemotherapy in hormone receptor-positive HER2-low patients who had received prior endocrine therapy and 1 to 2 lines of chemotherapy. The intracranial activity of T-DXd is also relevant given Mila's subsequent CNS progression. An ESMO guideline assessed the T-DXd as MCBS score 4 for the HER2-low patient post-chemotherapy and MCBS score 3 and the early chemotherapy naive setting per DESTINY-Breast06. This slide summarizes the key eligibility criteria and OS for the major ADC criteria. DB04 showed significant overall survival benefit who received 1 or 2 lines of chemotherapy in the metastatic setting or recurrence less than 6 months after adjuvant chemotherapy, 1 or more line of endocrine treatment. And TROPICS show that also show overall survival benefit in HER2-low. And in TROPION-Breast01, who received 1 to 2 lines of chemotherapy in the metastatic setting, unfortunately did not meet the co-primary overall survival benefit. DESTINY-Breast04 is a multi-center randomized open-label active control phase 3 trial for the patient who received 1 or 2 lines of chemotherapy in metastatic setting compared with chemotherapy versus T-DXd. As shown here, you show T-DXd showed median PFS of 10.1 months, which is statistically significant compared with single-agent chemotherapy, and also for the overall survival benefit from 70.5 months to about 2 years. The clinical benefit of the T-DXd over TPC was maintained regardless of BRCA1 gene alteration status, and there was no statistically significant biomarker interaction. However, if you see here, the trend for the shorter PFS was observed in both treatment arms in patients with BRCA1 gene alteration compared with those with no alteration detected. Let me move to DESTINY-Breast06. DESTINY-Breast06 is a T-DXd compared with chemotherapy for the patient who did not receive chemotherapy in the metastatic setting and prior 2 or higher line of endocrine treatment plus targeted therapy for the metastatic breast cancer and 1 line for metastatic breast cancer and progress within 6 months of starting first-line ET plus CDK4/6 inhibitor, recurrence less than 24 months of starting adjuvant endocrine treatment. As shown here, T-DXd showed the absolute benefit of 5.1 months compared with TPC in HER2-low population and also for the HER2 ultra-low population. Especially for the PFS by time to progression on first-line endocrine as CDK4/6 inhibitor endocrine resistance shows that if you have less than 6 months of time to treatment failure like Mila, you can, although she received inavolisib, the T-DXd showed a median PFS 14 months compared with 6.5 months compared with TPC, which shows that T-DXd improved PFS versus TPC regardless of time to progression on first-line endocrine treatment with CDK4/6 inhibitor or type of endocrine resistance. Interestingly, TDXD improved PFS versus TPC regardless of ESR1 mutation status, and also interestingly, if you have a BRCA mutation and receive the TDXD improved PFS versus TPC regardless of BRCA1-2 mutation status, and potential greater benefit with TDXD was observed in mutant subgroup. Okay. Discussion point 6, and the most complex one, what the optimal third-line strategy for Mila, who now have 3 brain metastases plus lung and liver progression after capecitabine. Let me address CNS management first. 3 brain metastatic lesion in patients with ECOG1 should be managed with stereotactic radiosurgery if possible, rather than whole brain radiation. However, if the patient has asymptomatic brain metastasis, you could try the TDX first because she has a HER2-low disease with systemic metastasis. If germline BRCA2 confirmed, olaparib or talazoparib could be considered first, and CNS activity of PARP inhibitor supported by retrospective data and mBRCA clinical trial. However, if you have only tumor BRCA mutation, TDXD may be preferred regimen considering CNS activity demonstrated by the DESTINY-Breast04. Caution with ILD or PARP inhibitor based on tumor BRCA2 mutation and alternative sextumagovitecan if available. This is the intracranial efficacy in patients with asymptomatic brain metastasis from DESTINY-Breast04. Patients with TDXD arm had cranial overall response rate of 25% and CBR was about 60%. And the median CNS PFS by BICR for patients with TDXD was 9.7 months, and median overall survival for patients in the TDXD arm was 60.7 months. This table summarizes the antibody-drug conjugate for the hormone receptor positive HER2-negative metastatic breast cancer. Trastuzumab deruxtecan may be considered for patients with HER2-low or ultra-low metastatic breast cancer after at least 2 lines of endocrine therapy for MBC or 1 line of endocrine therapy for MBC if progression occurred less than 24 months of one endocrine treatment or 6 months of the endocrine treatment with CDK4 inhibitor for metastatic breast cancer. And trastuzumab deruxtecan is recommended for patients with HER2-low metastatic breast cancer after 1 line of chemotherapy based on DESTINY-Breast04. Sextumagovitecan, which is a TROP2 ADC, should be considered for patients with hormone receptor positive HER2-negative metastatic breast cancer after at least 2 lines of chemotherapy. And datopotamab deruxtecan may be considered for patients with hormone receptor positive HER2-negative breast cancer who were previously treated with chemotherapy based on TROPION-Breast01. And SG could be considered for patients for HER2-low or ultra-low after prior trastuzumab deruxtecan. For case of the Mia, I would recommend TDXD for the next line treatment considering she has a visceral progression with CNS progression in HER2-low disease. These are the guidelines for chemotherapy. The optimal sequence of therapy in metastatic breast cancer has not been established. Available options should be discussed with the patient, and sequential single-agent chemotherapy is generally preferred over combination. And in patients where a rapid response is needed due to immediate organ failure, combination chemotherapy is preferred. Chemotherapy should generally be continued until progression of disease or interval toxicity, and rechallenge with the anthracycline taxane is feasible in patients with disease-free survival of 1 year or longer. The combination of taxane or capecitabine with bevacizumab still alive, if available, is an option for the first-line chemotherapy. If capecitabine is used, patients should undergo germline variant testing for the lack of enzyme DPD before starting treatment, which is lower level of evidence. There are many emerging data, including EVERA, giredestrant plus everolimus versus SOC plus everolimus, who failed previous CDK4/6 inhibitor plus AI and 1 or 2 prior line of endocrine treatment. And in near future, our metastatic breast cancer guideline might include those options. And also, Korea 1 is a landmark trial that has now provided high-level evidence of genital of pan-PI3 kinase and mTOR UR inhibitor in combination with palbociclib and fulvestrant in post-CDK4/6 inhibitor setting. The primary endpoint in PIK3CA wild-type patient showed a striking hazard ratio of 0.24 with median PFS improved from 2 to 9.3 months, and overall survival data presented at ASCO 2026 increasing, and we are expecting to revise our metastatic breast cancer guideline in near future. The final point on this second line question was local ablative treatment indicate for villus lung lesion. The answer is no, and this slide explains why. And oligoprogression is defined as limited progression, typically 1 to 3 sites, while the majority of disease sites remain controlled on systemic therapy. This is the fundamental different entity from the Mila situation. And February 2026, Mila has 5 new pulmonary lesions, the largest measuring 18 millimeter, while liver and bone remain stable. 5 new lesions by any consensus definition constitute polymetastatic progression, not oligoprogression. ESMO guidelines support stereotactic ablative radiotherapy only for 1 to 3 sites with controlled systemic disease with an expectation of that systemic therapy continues. In Mila's case, the appropriate intervention was systemic therapy change, which occurred with capecitabine or maybe TDXD earlier, rather than local consolidation. Part of our role as oncologists is to explain clearly when local intervention are unlikely to alter the disease trajectory and when systemic treatment remains in the evidence-based priority. Thank you for your attention.
Thank you very much for all the speakers. It has been a real pleasure to hear all these cases and the discussion. I think the treatment of patients with hormone receptor positive HER2 negative in the metastatic setting has become very complicated because we have so many options, and I would like to hear from our panel today that you have Ana Tessici, Seok Ayam, Giuseppe Corigliano, and Nadia Harbeck. We do have quite some questions from the audience, and I will try to answer all of them in this period of time. So I will start with the first question and I direct this to Anna. Anna, as immunohistochemistry subtypes do not fully mirror genetic subtypes, would you consider any additional tests of tumor biology in such cases where standard treatment does not give expected results and disease course is somewhat unusual?
Well, thank you, Evandro. I would say, obviously, in this patient, we had the comprehensive genomic profiling done, so the NGS, and also we did the germline testing. So basically, we cover both the 2 standard diagnostic options or approaches. Possibly, we could consider also rebiopsying or considering the liquid biopsy at this point.
Okay, thank you. I have a question to Nadia Harbeck, because this is a more surgical question, Nadia. Could you offer sentinel node biopsy after neoadjuvant chemotherapy, even if axillary lymph nodes were positive in the beginning?
Yeah, I think what our colleague means is that they were positive and then downstaged after the neoadjuvant chemo. Yeah, we can do that. It's recommended to at least clip a node before and verify that the patient was node positive, clip the node, and then if the patient downstages clinically, you can do a sentinel and a targeted axillary dissection. We saw data at San Antonio last year that is as safe as axillary dissection in this case. There was even one curve that Torsten Kühn presented at San Antonio where he sort of showed that sentinel was as good as targeted axillary dissection, but I think the follow-up is very short. It's only, I think, 3 years. So I would still err on the side of caution and do a targeted axillary dissection, removing the clipped node as well. But it may be that in the future we can omit that step, but I think we need a bit more long-term data for that. But yes, downstaging makes reduced axillary surgery possible.
Yeah, so there is a lot of new studies on this area. Thank you, Nadia. Giuseppe, I want to hear from you. In patients with metastatic hormone receptor positive breast cancer that have PI3K mutation after the first line, how do you decide what's the better option between capivasertib or alpelisib, inavolisib? What are the specific features that you keep in mind, knowing that Inavo is for first line, not second line? Yeah.
But we have a study, of course, also in second line, actually. But I believe usually my decision is based on the magnitude of clinical benefit scale of ESMO. So I balance activity and safety profile. So to be honest, of course, alpelisib is not so well tolerated. I have a huge experience from early development, but also in clinical practice. Capivasertib is a little bit better tolerated than alpelisib. So my advice, actually, since we have only this one, is to use capivasertib in this setting. But you know better than me that we have new generation PI3 kinase inhibitors in the second line setting that are outstanding. One of these is Relay 2608 with an incidence of hyperglycemia that is less than 5%, and the other one is the LOXO agent under development again in endocrine resistant and endocrine sensitive disease that even more better in terms of tolerability. So up to now, I use capivasertib better as a tolerability respect to alpelisib. In the future, I will go for sure to the next generation PI3 kinase inhibitors that have a safety profile that is really much, much more better.
Yeah, I think that's always the main concern of the PI3K inhibitors, the safety profile with so many side effects. I have a question to Seok. In the context of a full NGS, what is the role of molecular tumor burden in the management of such case? What is the concordance rate between germline BRCA1 test and VAF of BRCA1 on NGS tested? So which one would you test? Would you test for the germline? Would you test for the somatic mutations?
Thank you for the question. So actually, although you have a full NGS, you might have several mutations like our patient, PCA mutation and ESR1 mutation and germline BRCA or tumor BRCA coexist. In that case, when you have a molecular tumor burden, you might discuss with your geneticist and the molecular biologist regarding which one is more oncogenic and which one is more effect for this patient trajectory. So I think it is very helpful to discuss with your molecular biologist and biostatistician for the bioinformatics regarding the prioritize the targeted agent.
Mm-hmm.
And the concordance between the germline BRCA mutation and tumor BRCA mutation is quite challenging question because maybe different according to the method and different according to the institution. For the germline BRCA mutation, traditionally we use the Sanger sequencing and also for the MLPA method for detect the long large deletion. But currently we can also use the OncoPanel, which is maybe less steps compared with the Sanger sequencing, but you can test multiple germline mutation at the same time, and the tumor BRCA mutation also detect if you test the germline and tumor simultaneously. You can say that you have a somatic mutation, but if you only test the tumor, you cannot say that is the somatic or germline. But if you have about between 40 to 60, you might have a higher chance to have a germline BRCA mutation who cannot affordable because of your national guideline. So I think depends on the case by case. You can use the germline test using the mononuclear acid from the blood, and also for the tumor, and maybe discuss about the your colleague. And for the VUS, sometimes VUS upgrade to the pathogenic in some instance. So following up the VUS is important, but not using the VUS as a treatment decision.
Yeah, thank you so much. There is another question that I think it really fits for Nadia in this case, because we are conducting so many studies in the neoadjuvant setting, seeing the drop of Ki-67. What are your thoughts on neoadjuvant endocrine therapy in early breast cancer with Ki-67 follow-up surgery? How can you use those, and how can you avoid chemotherapy in the early breast cancer setting?
Well, there is sufficient evidence, I think, from the UK, from the Poetic trial, as well as from Matt Ellis's group in the US when he was in St. Louis, I think, and as well as from our group, that if you have a drop or if you have a Ki-67 of 10% or less after 4 weeks of preoperative endocrine therapy, the tumor is highly endocrine responsive. And if you also have a gene expression result that is low risk, then you can avoid chemotherapy in patients with up to 3 lymph nodes pre and post-menopausal. The outcome data are very, very good. So I think it's an easy method. You can also use it obviously without a genomic assay if you have financial restrictions, and it's a very inexpensive method to test endocrine sensitivity and gives us very good results. People are a bit scared sometimes because of the Ki-67 and the standardization, but the low Ki-67 we're looking for here is actually very standardized, and the pathologists agree in a high percentage, over 90% agreement here. So it's easy. You do the second Ki-67 in surgical specimen. It doesn't bother the patients, and you can schedule your surgery much better. And it's also recommended in the ESMO early breast cancer guidelines because it has a very high level of evidence.
Yeah, I think it is an important message, but it really needs to be standardized between pathologists. That's very important. They need to get together. So another question that I would address to Anna. In patients with metastatic breast cancer in BRCA1 PVs, what is your opinion on the application of first-line PARP inhibitors therapy? Having in mind that loss of RB1 and BRCA1 mutates treated with CDK4/6 inhibitors. So would you consider having PARP inhibitors as first line in patients with pathological mutations?
Basically, the robustness of data and the level of data supports the CDKs to stay as the first line option in metastatic hormone receptor positive HER2 negative breast cancer. And I would always prefer that as a first line choice. But we also know from the PARP inhibitor trials, the Olympiad and BRCA trial in metastatic breast cancer, that moving the PARP inhibitors to prior lines rather than later, we have better results. So definitely in this patient, we did not have germline mutation present confirmed. But in case that was the case, the PARP inhibitor will definitely be an important option, but after the first line treatment.
Okay, I fully agree with you. I want to address this question to Giuseppe now. You have a patient who progresses metastatic disease, but only in brain, no other metastatic sites. After local therapy, what would you do? Would you start systemic therapy for metastatic breast cancer? Would you wait this? You just do the local treatment? What would be your approach? So hormone receptor positive, HER2 negative, who progress on brain only as first site of metastasis.
It depends, of course, on the clinical history. No, if you have a patient that received an AI plus a CDK4/6 inhibitor for 2-3 years, and we have only one single brain mets, and you perform an MRI and is really single, I would discuss surgery followed by radiation therapy, and personally, I would continue with the same treatment. We know perfectly that now management of oligoprogressive disease seems to be a new challenge for the future because we have so highly active treatments that potentially you can integrate local regional treatment and continue with the same therapy as we do in HER2 positive disease. So in this specific patient, for sure, I will treat locally and I would continue with the same treatment. Eventually, maybe I will test for ESR1 to understand if there is any mechanism of resistance. And if I could do, I will change maybe the endocrine agent and the CDK4/6 inhibitor, but the strategy would be exactly the same without modifying the treatment algorithm.
Yeah, I think I fully agree with you, Giuseppe. If you have only brain progression, yeah, you really need to treat the brain and continue with the same systemic treatment. Of course, if you have systemic disease, is a different approach. So I have just a final question because we are reaching the end of this webinar. So, and I'm gonna address to all of you. If you have a patient who is on CDK4/6 inhibitor, it doesn't matter which CDK4/6 inhibitor in the adjuvant set, and progresses like 6 months at the end of the adjuvant CDK4/6 inhibitor, which would be the first line treatment that you use? How you would treat this patient?
I think we need to look at the paper of Sarah Tolaney, where she looked at the patients relapsing on or shortly after abemaciclib, and half of them lost ER expression. So I think the first line treatment would have to take into consideration a biopsy of the metastasis. And we also know from the monarchy study that the patients that relapsed very fast, a great majority of them got chemotherapy. So there seems to be a very aggressive tumor biology. So we have to see the biology and then decide whether we're going to do some more biomarker testing, like go down the road that Anna has shown us for her patient, or whether we need to go to chemotherapy. And then I'm looking at Giuseppe. TDXD first line is probably also a good option in this case.
Yeah, just a last comment from Giuseppe.
I agree completely with Nadia. With Nadia, we have a full agreement in clinical decision because we take care of patients, and I believe she absolutely suggested a good strategy. In case you have more than one lesion, in that case, really, I would consider another strategy. So completely in agreement with the clinical decision making that she proposed.
Okay, so with this, I would like to thank all the panel, Nadia, Giuseppe, Seok, Anna. It was a very nice webinar. I would like to thank everyone for attending this. And at the end of this webinar, you're gonna have a questionnaire to complete to see how we can improve this and to get your certificate. So another thing, the last comment that I want to say, that the new ESMO guideline for the metastatic breast cancer is going to be published very, very, very soon. So be attentive to that. So thank you very much. Enjoy the rest of your day, and see you in the next ESMO on-air meeting. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.